In this presentation, I will be demonstrating how to mix two different types of insulin. Firstly, you have to know which insulins are syringe compatible, which ones can be drawn into one syringe so as to give the patient only one injection. And that's just based on your nursing knowledge. You have to remember, commit to memory those that are compatible and those that must not be mixed with any other insulin. Today, I am giving NPH and regular. And these two types are compatible. NPH is compatible with regular. It's also compatible with the rapid-acting insulin. So NPH is a basal type of insulin that can be mixed with regular and the very rapid-acting insulins. There is a methodology to this, however, because NPH insulin is a suspension. There is a protein additive in it, which prolongs its absorption. And so you will find that it is cloudy, and when we mix it, we have to be very certain that we mix in the order of clear to cloudy. So there's a set number of steps that we have to follow in order to do this correctly. So I'll begin this process. We will assume that I have checked the order, I have checked identifiers and allergies, I have checked the blood sugar, very important, and the meal trays are being passed out as we speak. So I'm expecting the meal tray any minute here. And so I have my two types of insulin. I have NPH and regular, and I have 18 units of NPH to give, and I have 8 units of regular. So I'm going to start first by preparing the NPH and mixing it so that I disperse the particles evenly throughout the fluid, and that's a very important step because that is going to affect onset, peak, and duration. If it is not adequately mixed, that will cause it to work a little more quickly than what's anticipated. So sometimes people will roll it between their hands, and Perry and Potter advocates this. Some sources will say kind of toggle it like this, but in whichever way you're doing that, you have to just make sure that the particles are distributed evenly throughout the fluid. Then I'm going to go ahead. I've washed my hands. I could put on gloves. Gloves are optional at this point. I'm going to go ahead and I'm going to decontaminate the tops, and because I have two, I'm going to use 2 different alcohol pads. And I would scrub, of course, for 15 seconds. Okay. Assuming that it's been 15 seconds. All right, so I have, as I said, 18 of NPH, 8 of regular. I have 2 even numbers, and the total is going to be 26 units. So I can use either syringe, either the low dose insulin syringe or the high dose. The important factor is that you have the exact marking, and I have the exact markings here for all of those numbers. I'm going to uncap and place my cap at the edge of the table here. I want to insert air into my NPH, but I will not draw it up. So I'm just going into the center of the bullseye. I want to be sure that the needle doesn't touch the medicine, and I'm just pushing air in, but I will not draw it up at this time. I'm basically getting it ready. And then I need 8 units of regular, so I'm going to go ahead and put 8 units of air in my regular vial, being careful to check and double check. 8 units of air, but this time I'm going to go ahead and draw it up. Okay, so I have the 8 units of regular. I'm going to put that off to the side so I don't inadvertently grab it again. And now I need 18 units of NPH, If my particles have settled, I can give it another toggle here or two. Just be sure not to touch the top. And then the very important part when drawing up the NPH is to remember that the NPH and the regular will mix immediately. So the two types will mix as soon as I draw the NPH into the syringe. So when I drew up the regular, I had the opportunity to work with air, any kind of overfill. You can work with the regular as much as needed. But when you have the NPH in the syringe, we have the two that are mixed, and so therefore, if you overdraw or if you pull air into the syringe, there is no way to fix that without affecting the regular dose. So the bottom line is we have to make sure that when we draw the NPH that we are certain that the needle is submerged in the fluid so that I don't pull up any air, and that I know my combined total, which in this case is 26, I have to pull back very slowly, and I have to stop precisely on my marker. If I inadvertently overshoot it, I would just have to put this in the sharps container and start over again. At this point, when we're, after we've drawn up the NPH, as I said, there's no margin to mess around with anything, so you would just go ahead, recap, and your injection is ready to give. Now I'm ready to give the injection. All of my checks and balances have been satisfied, so to review, I have checked the patient's blood sugar. The meal is on site. I checked identifiers, allergies, the medications against the EMAR 3 times. I've scanned everything in. I've scanned the wristband, and I also have gotten a second nurse verification because, as you know, insulin is high alert, and we must be sure that we are very accurate. So I have second nurse verification. All of my checks and balances are in order, and now I'm ready to give it. The site of choice for insulin is the abdomen, and we rotate within the abdomen. And the angle of insertion is, for sub-Q, it's between 45 and 90 degrees. And we're going to take into account the patient's weight, the needle length, and the site selection. So most of the time with insulin, because the insulin needle is short and fine, most of the time we're at a 90-degree angle, but we really have to gauge it based on those three variables. If we have someone with very little peripheral sub-Q and we have a 1/2 inch or 5/8 inch needle, it may be appropriate to go at a 45-degree angle. In this case, I'm going to go ahead and I'm going to go at a 90-degree angle. So I'm going to open up a 2x2 for when I'm done with the injection, and I would just go ahead and expose the belly, let the patient know that I have their insulin injection before their meal. I'm going to find my site and clean it off starting in the center, working out about 2 inches. I can point to the area that I've just cleaned to make sure that I don't lose sight of it. Uncap. I'm going to pinch in this case. If someone is very large, I don't need to pinch, but I do need to support the tissue. So you might be pinching to elevate the sub-Q, or you might just be supporting the tissue and stretching. Okay, let them know you're going to feel a pinch, and then go ahead and inject. Remove, and a gentle touch of pressure for comfort. Okay, uncapped needle right to the sharps container. And then we would cover our patient and get her ready to consume her